Hello, welcome to the Standing Committee on Health and Social Development. My name is Gordon McNeely. I'm the chair. Today is Wednesday, September 30th. This is the 1 o'clock meeting. With us today we have Tricia Altez, Heath McDonald, Brad Trivers, and Corey Deagle replacing Mr. Jamie Fox, and Hannah Bell. So can I get a motion to adopt the agenda? Brad Trivers. And today we've got two presentations, so what we're planning on doing is trying to give you about half an hour for your presentation and then maybe half an hour for questions, and we'll try to keep it to that. So I'll pass it over to Tayte and Courtney to introduce themselves, and then you can get started in your presentation. So.
Thank you. My name is Tayte Willows. I'm the Acting Director of Programs with the Canadian Mental Health Association PEI Division, and with me is Courtney Cudmore, who is one of our peer support staff, and also acting as our peer support coordinator right now. So we're very glad to be with you today. We also wanted to pass along regards from Treena Smith, our ED. She wanted to be here, but schedules just didn't align that way. So thank you for inviting us to share about mental health and our experiences through COVID-19 as a nonprofit on the ground. This conversation is really timely, and we're grateful for your eagerness to explore this conversation more fully. I also wanted to recognize that today is Orange Shirt Day, where we take up the truth of our history with residential schools and the 60s scoop here on the island, and then move forward in our policies and efforts in the hope and spirit of reconciliation going forward. Today, we're going to try and keep it to about 15 minutes to give you as much time for questions as possible. We'll see how that goes. We're going to start by going through some research that's been happening nationally, talking about our experiences as staff on the front line, and then going through what we think might be coming on the other end of the hill. If you can hold your questions till the end, that would be great. Did I miss anything? You're good? So I did share with each of you an infographic that was produced by Cmha National. So if you weren't aware, the Canadian Mental Health Association is part of a national federation. So we have divisions across the country, all 10 provinces as well as the Yukon, where we're delivering programs and working to improve mental health for Canadians across the board. This research that's in front of you was a collaborative project between Cmha National and the University of British Columbia to try and get an idea of how this COVID-19 pandemic is affecting the mental health of Canadians. If you're interested in the details of how the study was conducted and all the ethical pieces that come along with that, you can find more information on the back sheet, which will link you to their website. I would encourage you to go through this document, as well as there's going to be tons more research coming out. This is quite a hot topic, as you can predict. But there are a few pieces of this that I wanted to pull out from national research before we jump into what we're seeing here on the island. So the first is that of the people who participated in the survey, which was a representative sample from across the country, we saw that 38% of people said that their mental health had declined due to COVID-19. So that's almost 40% of people in our country have said they're not doing as well as they were before. This pandemic is having lasting impacts on them. We see almost half of people who took the survey reported feeling anxious or worried. I also, in this infographic in two different places, I'll draw your attention to one of the things that we're seeing is that there's a rise in unhealthy coping strategies. So we're seeing an increase in the use of drugs and alcohol. And this notably was reported among parents and caregivers within this study. So they reported a 12% increase even within their own coping while trying to deal with the stresses that come along with raising a family through this pandemic. And then the last piece of this research that I wanted to highlight is the increase that we're seeing in suicidal thoughts. So for the past 10 years or so, rates of suicidality have remained pretty consistent, around 2.5%, which is exactly what was reported in 2019. And through this survey, we found 6% of people were experiencing suicidal thoughts, which is a pretty dramatic rise. That's a pretty stark increase to be seeing within suicidality. And that goes up even higher within groups that experience higher levels of discrimination or marginalization. So for folks who were already dealing with a mental health struggle or dealing with a mental illness, their rate was up to 18%. So nearly 1 in 5 people were dealing with suicidality. So I would encourage you to look through this. There's lots of really interesting things. You could write tons of academic papers on this if that is what you one day would like to do. But I also wanted to draw that back to what we're seeing here on the island. So while these results are alarming, they do seem to be pretty predictable in terms of what we know about mental health and what we know about mental illness. So just to clarify some terms, because I know that sometimes terminology can get all over the place. When we're talking about a mental illness, we're talking about something that is a diagnosable condition, something that can be, there's treatment options available that doctors are able to be involved in. When we're talking about mental health, we're talking about the overall well-being that someone experiences. So that usually is a culmination of how they feel about themselves, how they feel about their relationships, and how they feel about the world around them. Encompassed in those things, you'll find topics like self-esteem, identity, purpose within how we feel about ourselves, our relationships with friends, families, and colleagues within how we feel about our connections with other people, and then our sense of safety, security, and belonging in that how we feel about the world around us category. Encompassed in this definition, you'll find most of the typical coping strategies that we would encourage people to use, as well as any attributes that we typically attribute to resilience for folks who are able to navigate stress in their daily lives. So when we hear about those things and we hear about how we would kind of define mental health, it's no surprise to me that we're seeing changes based on this pandemic. So I would encourage you to reflect on your own experience. I don't think any of us are immune to this change. I have not spoken to a single person since April, really, who has told me that they're doing great, other than the typical island of yeah, I'm doing great. And so I think it's important for us to be reflecting about how this is affecting us as leaders and service providers, as well as for the people who we're trying to support and care for. Some of the things that I have heard is that people are really struggling with how they feel about themselves, that category of mental health, because of the changes in employment. So the layoffs, the unemployment, the furloughs, all of that is affecting how people feel they're able to support themselves and support their family, and that's affecting their self-esteem and their self-efficacy. So we're seeing that have a negative impact on their mental health. Similarly, we're seeing changes in working conditions, so people being asked to work from home, work remotely, basically learn a whole new set of skills in about a month, and that's affecting the way people feel in terms of their ability to do their jobs well. And when we don't feel like we're doing our jobs well, we tend to not be doing as great mentally. So I've been hearing a lot of that within my position. I guess to give some context for that, I do a lot of our phone calls at Cmha. So when people are in crisis or need help, they usually call me first, and then I'll connect them through to Courtney, and then I do a lot of our public education workshops. We're also seeing within the relationships area, we're seeing changes for friends and family, and this is happening kind of all over the place. For folks who didn't have a strong network before the pandemic, who would have relied more on society-wide interaction to feel as though they were contributing and participating in their communities, they're experiencing high levels of isolation and loneliness because they're not able to just go and sit at the Tim Hortons anymore. There's changes in what their typical routine would look like. And then on the flip side of that, we're also hearing about high levels of stress and conflict within homes because we're changing the contract. We're changing the rules about what partnership, what marriage, what friendship looked like before. And spending a lot of time together can be stressful. And so we're seeing that bear itself out on these personal and intimate relationships within partners and then also within children. And that is also reflected deeper into this report. And then the last piece, probably most evidently, I think, to most people, is that we're seeing how we feel about the world around us is just kind of ever-changing ground. We're seeing high levels of fear and anxiety for people as they leave their homes. We're seeing deteriorating levels of public trust in terms of my ability to believe that you're doing your best to contain this virus. And so because we're not really trusting how our neighborhoods are functioning, it's making it harder for us to feel safe and secure within the communities that we're living in. At this point, I also want to acknowledge that these changes are some that we are currently experiencing, but there are many people in our communities who this is not new because of COVID. There are lots of people who their socioeconomic status and their other social determinants of health would have been putting them in a vulnerable position even before the pandemic. And we want to recognize that addressing the need of everyone can't mean forgetting about their needs that existed in the first place. So with that, I'm just making sure I didn't miss anything. Yeah, so with that, I wanted to hand things over to Courtney. So Courtney is one of our frontline staff. She's been working with peers throughout the pandemic and helped to really guide us through what service delivery in a pandemic could look like. So I'll hand it over to you.
Thanks for having us today. My name is Courtney Cudmore, and I'm one of the peer support workers with Cmha. I have bipolar disorder and post-traumatic stress disorder, and I have dealt with mental illness for over half of my life. I began attending peer support meetings in 2018, and for the first time in my life, I felt accepted and understood. I was able to take my mask off and be true to myself. Peer support is a supportive relationship between people who have a lived experience with mental health, and we offer support, encouragement, and hope that recovery is possible. We have lived through what someone else is experiencing. We are located currently in Charlottetown and Montague and have seen approximately 200 peers since the program came to the island less than 2 years ago. There are currently 2 peer support workers in the Charlottetown office and 1 at the Montague location. We offer a confidential, non-judgmental, safe space to share what you're going through, whether this be through one-on-one support and or through our 2 support groups, which we run on a weekly basis. We help peers navigate the mental health system based on their experiences and what they feel they need. We help to bridge the gap between the peers and other community resources, as well as collaborate with other resources such as counselors, psychiatrists, and places such as McGill, Richmond Center, Addictions, Hillsborough Hospital, and Unit 9 at the QEH, where we present the programs to new patients who are in need of support during their stay and after they've been just discharged. We also have run a support group at Unit 9, which has currently been put on hold due to the pandemic. We advocate by attending appointments with a peer if they feel they are having issues in communicating with their other resources, as well as providing crisis intervention when needed. If a peer is in crisis, we go to the hospital and stay with the peer while they are being triaged, and will remain with them during the entire process. This helps people to feel that they are not alone during a very difficult time. And we also help collaborate to facilitate courses and workshops offered to the community, such as the Cmha PEI Learning, Training, and Support Hub. When the pandemic began, we quickly had to adapt to the new normal and moved our services virtually. Appointments were done over the phone and support group meetings happened over Zoom on a weekly basis. For many, we were their only support system. So how did people fare during the lockdown? The pandemic affected every individual, regardless of their mental health. As peer support workers, we have worked frontline during COVID-19. Since the pandemic began, we have seen an increase in peers struggling with depression, anxiety, and taking care of themselves, with so many reporting fears of the unknown. We have also seen an increase in those reporting feelings of isolation, as many could no longer see their loved ones or access supports like they used to. Hopelessness and grief was also prominent in those we support, as they grapple with the fear that the world may never go back to the way it was, and many missed important milestones, events, and some have lost their jobs. We also have witnessed a drastic increase in suicidal ideation, self-harm, and suicide attempts. Now that we have reopened, how is everybody coping? Now that we have reopened for individual appointments, people have been coming in on a regular basis in order to feel a genuine connection. We do still have some individuals who prefer to access peer support over the phone or virtually due to health or mobility challenges, while others are still struggling to leave their home to interact with the new normal of the outside world. Exhaustion and burnout are consistently reported as people are overwhelmed and struggle to process all the changes in our community. We have had many individuals talk about turning to unhealthy or dangerous coping strategies due to being unable to access their supports or having a difficult time adjusting to the ways they can access them. Hopelessness, suicidal ideation, and suicide attempts are still prominent, even though many resources are now beginning to allow in-person appointments. People have often had to turn to seek emergency support at the urgent care clinic at Hillsborough Hospital, as well as the emergency department at the Prince County Hospital. What services and supports that were really crucial and helpful to our peers during the pandemic? Individuals were still able to access the resources such as counseling and psychiatry during the pandemic through phone or virtual appointments. Having these resources during this difficult time was of the utmost importance. That being said, not being able to go in person to access their supports left most people feeling a loss of connection and understanding. Hospitals such as Hillsborough and the Prince County Hospital were too often turned away by many people, as there were high amounts of those in crisis. Peer support is also what people have turned to during this drastic change in the world. Now more than ever before, people need empathy, understanding, connection, and support from those who understand. We had many reporting feeling as though they were heard and understood as if they were talking to a friend while we did our Zoom support groups on the internet. So the pieces that were missing to support wellness, the main things that was reported was just the in-person connections was the most commonly discussed. In-person support from loved ones was also greatly needed, but unfortunately unable to happen due to social distancing and restrictions. So many spoke about their supports and coping strategies being centered around seeing people, including family and friends. So how are we as peer support workers doing during the pandemic? During COVID-19, we have all experienced the feeling of being overwhelmed by the amount of people in need of support and how much support they require during this difficult time. Due to how the pandemic has affected everyone and how it has left many limited in support systems and in crisis, we have been working while feeling helpless in how much support we can offer. Countless individuals have spoken about needing therapy they cannot afford, long-term counseling and psychiatry that they are unable to access due to long wait lists and needing to see their current resources more often than they do. Other reports financial struggles, issues with finding affordable housing, and feelings and thoughts of suicide. We instill hope in recovery, empathize and support people as best as we can, but still we feel so limited in what we can do to help those in need. So that's kind of what we do at Peer Support.
Excellent.
Yeah, so based on what we are seeing on the ground and what Courtney has described here, we're seeing across all the services that we provide at Cmha with the clients, members, and peers that we work with. We believe we're seeing evidence of a decrease in mental wellness. The fear for us in that is that a decrease in mental health risks an increase in mental illness. And mental illness is a lot more difficult to kind of get a handle on in the community. It's doable and it's something we can manage and we do right now, but we are looking forward at what's coming next, and we're not sure that our systems are prepared for that rise in mental illness that could be around the corner. The challenge is that our system here, as hard as our doctors, our nurses, our OTs, our psychiatrists, our psychologists, as hard as everyone is working, we know before the pandemic we were functioning at capacity, if not over capacity. And so to risk seeing an increase in the people who are reaching out for crisis support, an increase in people who are reaching out for treatment options, our system can't handle it. We don't have the space for people to get the support that they need. And that's within our own services. We know that we are functioning at capacity. And we want to make sure that people get the support they can, which often results in staff overextending themselves and putting themselves at risk of experiencing mental health struggles as well. So what we can do, because we don't want to leave you with that not so helpful note, is to use the same analogy we've been hearing about COVID this whole time, that we need to be physically distancing so that we can allow our hospitals time to prepare. We need to be washing our hands so that we can prevent the spread of disease. We need to be mobilizing community supports so that we can flatten the curve of mental illness that could be coming down the line. And that includes a bunch of different things. Community supports are varied across our island, but we have a beautiful grassroots network of groups that offer everything from education and empowerment, community and connection, as well as tangible supports around food and housing and income support. There's all kinds of people who are working on the front line to be able to provide these services in their community. And that includes other nonprofits like ours, as well as volunteers who are doing this because it's a passion of theirs. By mobilizing our community, by properly funding them, by properly promoting them, and by integrating them in with services, we're hoping that we'd be able to really empower those communities to reach their full benefits. So that includes improving mental health for the people that they're working with through those three areas we talked about: improving their self-esteem and their feelings about themselves, improving their connections, and improving how they feel about the world around them. We also believe that community supports help to address inequities that we see within our systems because they're able to target groups in ways that they have personally lived through. As Courtney shared, one of the beauties of our peer support program is that people who are there to help have been down that road before. And we see that in all kinds of organizations. It's the magic of AA. We see it happening within Peers Alliance on the island. There's all kinds of nonprofits that use their own lived experience to move other people forward. And the deeper goal of that is that it then works to build resilience for whatever's coming next. If we hit a second wave, if there is another global stressor that hits, by allowing these community supports what they need to be reaching the communities and partnering with them in that endeavor, you're allowing our communities to build more resilience for whatever stress comes next. I know that seems really vague, so to kind of put it down, we know that this is a partnership with the formal system. We know that the formal system can't operate without community supports, and community supports cannot operate without the support of the formal system. They need to be working together, and that involves integration of their services and staff, awareness of their services and staff, as well as funds that are shared throughout those services. So, that's okay. There's currently construction right next to our office on Fitzroy as well, so this is just like my regular life these days. Oh yeah.
Keep going.
Is that good?
Yeah.
I was doing a session this morning and a window fell out of the window frame, so this is fine. What I'm trying to say is that we at Cmha are nervous. We see the data that's coming in nationally. We're hearing the experiences of folks across the board, people who have been struggling previously.
No, we're gonna, we're gonna take just a minute recess. We're back. So with our presenters, we'll let you continue as you see fit. Great.
Perfect. We're nearly done. This is our last slide for you. Yeah, so I guess to kind of summarize what we've been talking about, we're seeing the national data that's starting to come in. We are hearing experiences of people on the ground, of staff who are providing frontline support. And we're seeing the increases in anxiety, in stress, and in suicidality. That makes me nervous. I see a reduction in access to coping strategies and the typical ways that people would be dealing with their stress, and that compounds my nervousness. Personally, I think that we are in the eye of a perfect storm. We've come out the other side of our temporary lockdown measures, and we feel as though we're starting to open back up again. But I believe that on the other side of this, there are going to be the deep felt impacts of this collective trauma that we've just gone through. And I think that when that happens, our island needs to be prepared. We need to have a network of community supports that can act as a preventative measure against whatever is going to lie on the other side. So yeah, thank you for having us today. And we're happy to take any questions you have.
That's great. Great job. So we'll start with Heath.
First of all, thank you for the presentation. But I also, Courtney, thank you for everything that you do as peer, because I think, sometimes you're the unsung hero that we don't hear of very often as individuals, especially in political positions. Your strength, being here today and explaining everything that you've done is pretty uplifting for this side of the house, I'm sure. So I just wanted to make sure that we appreciate you. So you stay focused and help as many people as possible. And hearing that number of 200 people in 2 years is pretty phenomenal. I'll tell you, personally, I don't know about the rest of the members, but I've been hearing lots about mental health. And it just continues to keep evolving and growing. And there needs to be changes. I don't know what it is. I just come out of government. I'm not blaming this government. That's not why I'm here or what I'm doing or why I'm saying it. There needs to be changes. I've spoken to nurses that have been in this mental health for 32 years, most recently. 15 years, I think she had at McGill Center. She's saying to me, you need changes. You need to fix this, you guys. And it doesn't matter what government's in. These are people's lives we're dealing with, and I think it's extremely important that we all come out on the same side of this, and COVID has put a lens on this, and there's a gap, and we're seeing that gap. I don't know what the answers are. I'm not, but I do know that if I can't change the tire, I know the tire's broken or it's flat, then get somebody else that can, and I think that's where we're at and government's at. And I will be later on here asking this committee to endorse a letter to the Premier asking for a Minister of Mental Health. And I hope they all endorse it because I think it's really needed. And I've just heard a couple of stories recently and they're pretty sad. So anyway, keep up the good work. That's all.
Thank you, Heath. Do you want to comment on his comments? No? Great. Perfect. Trish.
Thank you, Chair, and thank you so much, Courtney and Tayte, for this presentation. And Courtney, I echo what my colleague here has said about the importance of the peer support program and the work you're doing. And you had mentioned that it was Charlottetown and Montague, and I'm wondering, are there any plans to expand this fantastic program to Summerside or farther west?
I believe, we're looking into opening up in Summerside in the next little while there. I'm not exactly sure when, but that's what the hope is up in Prince County, or like Summerside area,
Trish?
Thank you. And so are there any additional supports that you need, that CMHA needs to move that forward, to expand this program with the great success you've had?
Yes, this is a wonderful program that we're seeing happen. And more staff will definitely be necessary to make that program grow. So as Courtney shared, we have 2 staff right now in Charlottetown. We have a 3rd who's on maternity leave, who will be coming back sometime at the end of the year. And then we also have 1 staff up in Montague. But between those 4 individuals, for them to carry the weight of this service for the whole island is a pretty big load. So we need the support for more staff. Further, we really want to be increasing the training that we're able to deliver to these individuals. So they're coming and sharing their own personal road of recovery. And so we want to make sure that we're equipping them with tools so that they can do that not only effectively, but also safely, so that they're not put into a vulnerable position by sharing something.
Trish?
Thank you, Chair. And I think, Courtney, you had mentioned as well around that you were still able to keep the program going even during the pandemic through the, phone calls and internet meeting over Zoom or whatever, that sort of thing, which I think is great, but also highlighting some of the limitations of that and that, it wasn't, it's not the same as meeting in person. So what have you learned, through that sort of experience of trying to navigate this program, while not being able to necessarily meet in person, that you might implement next time?
What we learned is how important social interaction is with everybody, and with the isolation and not being able to see your loved ones. That's where we noticed the decrease in mental health. So big thing is we are humans, we're human creatures, we love socialization and the importance of how important it is to have people around you. And so what we learned from that would be that it is still possible to do things online virtually, but it is very important to have the socialization aspect. So.
Trish?
Just one more question, Chair. So, Tayte, you had mentioned as well about, that the connections between the formal system and the community supports, and that they're both important and that they both sort of mutually support each other in the work of supporting Islanders in their mental health and well-being through all sort of stages. I'm wondering about communication between the formal system and community supports like the ones that that you described today. If you have any, if you could tell us a bit about what that's like, and if there are any suggestions for how to improve that communication to make sure that individuals are supported throughout every stage.
Yeah, I think that's a great question. So I guess I'll take it in two chunks if that's all right. So I think it happens on a case-by-case basis right now. Some programs are really open to having that broader collaboration and including different groups and different community supports in their process of care. I know that we have a number of nurses and doctors who work pretty closely with our peer support staff, and when an individual ends up in hospital, our peer support are the first people who get a call because some people are more willing to accept that at this point than others. And I think that happens across the board in all of our programs. Let it be the clubhouse, let it be our housing supports. Wherever you fall, you'll see differences based on each individual and each clinician and their relationship. Personally, I think a helpful recommendation would be for our variety of committees to revisit what we mean by circle of care legislation. So this is one of the recommendations that's included in the province's suicide prevention strategy, is to revisit who is able to be a part of case planning and who is welcomed in, respecting confidentiality and respecting privacy, but also recognizing that support is more than just that individual and their doctor, which currently is how that legislation is typically read. So that is one tangible thing that could be moved on. I also think welcoming more to the table, including more people in the conversations would be a helpful step to increase communication. So that is $1 million question.
Move to Corey.
Thank you, and thank you very much for both of you for coming in. There was an article in CBC that had Kids Help Phone, I think it was a 70% increase, and I'm just going to pull the quote. We have seen an incredible increase in the last 4 weeks alone, and this was back in April, right in the middle of the lockdowns. Top issues in PEI are an increase in sexual abuse, depression, anxiety, emotional abuse, and self-harming. Are these all things that you have seen over the past 6 months? That definitely.
And those numbers would be in line too with the island helpline that we have specific here for the island. In the month of April, we saw those numbers jump by about 200% as well. So they nearly doubled in that month. They're back to normal now, but at the time. Yeah.
Corey?
Thanks, Chair. And so I guess with the lockdowns, obviously it was done for a reason. But I wonder sometimes if it's actually done perhaps more harm in some cases than it's helped. And I guess I want to know what you both think on that. If if we had to flip the switch again and do lockdowns again tomorrow, is it the best way to go? Like, when you look at some of these numbers, like, it's fairly scary. And I don't know, I'm just curious if you have an opinion on that.
I think my mom would say the answer is hermeneutics. Like, we'll never be back in that situation again, in that we will never have not gone through it before. So when we first went into our lockdown, we rightfully trusted our medical professionals to be making the best decision they could to contain the spread of a disease that was ravaging the rest of the world. I think we'll do things differently next time. I think we've learned some really important lessons, but I don't think we can go back and change it. One of the things that I think that the lockdown has highlighted for us, and I had this conversation with Courtney before, is it gave all of us the opportunity to see really clear issues that have always been present. So this pandemic has shone a really bright light on mental illness, on racial injustice, on disparities in economic standings. And I think that it's giving us the opportunity now to address those issues in meaningful ways. But I guess to answer your question, I don't know. If I was the doctors in charge, hats off to them for acting as they did.
Corey?
I see in here it says obviously people with low incomes were more hurt by the lockdowns. And I often, and I know mental health affects everyone. But, there are some people that, during the lockdowns didn't lose their jobs, public servants, politicians. We all got our paycheck every 2 weeks, but that wasn't the case for everyone. People, especially in lower income jobs, they're just, those jobs are gone. There's jobs that are gone for good now. Is that something that, from your experiences in the past number of months, that it's affecting people more so with lower incomes or in those jobs that, obviously have been lost?
Yeah, we did have quite a few peers who did lose their jobs that were considered low income, and that made their lives a lot more stressful, and we've seen a regression in their mental health, big time. And they still are kind of struggling. They've not gotten their jobs back, or they're trying to find it, but so many people are applying, and yeah, we definitely seen an increase in low income people struggling.
And I think that issue is also compounded by the additional effects of lockdown. So I know for some of our clients who would be low income, they would depend on our services for 2 balanced meals a day at $2 a piece. And so when our services were shut down, until we were able to figure out how we're going to provide that service without them actually coming into the building, they wouldn't have had access to that meal service. And we see that in a variety of different services just with our own clientele. I know we've heard of it for food banks when they were making the adjustment to how to do service differently, as well as shelters, which is still an ongoing challenge that we're seeing for folks who are living with or dealing with homelessness. Accessing shelter and accessing emergency support that way has been an ongoing challenge.
Mm-hmm. Corey?
If there was, and I think Trish might have asked this question perhaps, but if there was something the one thing you need a government to do right away, what would that be right now to help?
We spent a long time talking about this question yesterday. I think this is the first step, recognizing that this is an issue we need to be acting on. And then I think it is reaching back to these community groups that are already partnering with the government and asking them what they need. One of the things we've heard, we're one of the largest nonprofits on the island, and from our community partners that we work with pretty consistently, is that not everyone had the flexibility and ability that we did due to our size to maneuver as quickly. So even things around administrative support, how do I create an operational plan? What do I do around these new stages? We know that tomorrow we enter into a color-coded system, preparing for that. And so reaching out to the organizations that existing contracts are with to be able to figure out what they need to deliver the service that they're supposed to be doing.
Good. Oh, Corey?
Sorry. Thanks, Chair. With Unit 9 being closed, did that I don't know if you can speak to that, like if that affected.
Yeah, it affected quite a bit. That limited really the only options to go to Hillsborough Hospital, which was pretty much has been full, or back to PCH. Also, there isn't as much programming, and we're hearing from peers at like Hillsborough Hospital, there's needing more. Like at Unit 9, you would have your daily schedule of what you would do, your groups in the morning. We're hearing that's not happening. So, yeah, the Unit 9, it's been a struggle with them being closed. So, yeah, a lot of people are being turned away. There's not enough beds, so, or they're staying in the emerge for a few days and then being released and then coming back, and just goes back and forth. It's just a circle, basically.
Okay, Corey.
And this is something that's still ongoing today?
Oh, yes,
Yeah,
yeah.
for sure.
Yeah.
Have you had any indication from government on when it might reopen, or what the plan is, or?
We haven't heard anything, yeah.
Not sure.
Good. Hannah?
Thank you, Chair. A couple of kind of following on from a couple of things. First of all, you said earlier something that really struck me, that mental health, or the breakdown of mental health, leads to mental illness. And I think we often it all kind of falls into one big bucket, but we're talking about two quite different things that are connected. It's on like you said, a continuum. So my question is mental health actually about health, or is it sounds to me, some of the things you've talked about, it's a lot more about community and the social network, as much as it is about where versus mental illness is illness that sits in the health space. But mental health sounds, a lot of the approaches that you're talking about are actually more about social intervention and social support. Does that fit? Yeah.
Yeah.
Okay. So, yeah, okay.
Yeah. I'll let you continue.
No, I'm just like, this is me articulating, this is how my brain works. And so I was saying it out loud. So mental health is not necessarily a health issue. It will become a health issue that requires treatment from a health perspective when as we travel closer to that space of mental illness. Because most of the interventions and things you're talking about are very much like what you said about loneliness and isolation and social connection and support and care. So my follow-up in that continuum is then, you mentioned the importance of the community partners, and this is something that I've talked about a lot in other spaces, and how critical it is, before we even got to COVID, how critical our community partners and the heavy lifting that they do in partnership with government. And traditionally, NGOs do the work the government can't or shouldn't do, right? But they can't do it with fresh air and sunshine, much as we would like that to be true. So something else you said that's really resonated is how difficult it is for administration or something when you literally don't get paid for your job. What kind of, you talked a little bit about some of the partners, and I know you're one of the largest NGOs in PEI. You mentioned Peers Alliance. What other partners do you work with? Kind of on a, can you just?
So I guess we'll answer this kind of in two parts, if that's okay. So I'll take the bigger picture stuff that we would work with, and then I'll let Courtney, because they do a ton of networking for their peers. And I also just want to pick up on what you said in terms of that continuum. A helpful analogy to think of is the same way we would look at physical health and physical illness. So even though physical illness would be treated in the medical space, right, in that health field, we wouldn't necessarily see nutrition and communities that are built for physical activity to be the responsibility of our doctors. And so mental health and mental illness function similarly. In terms of the partners that we're working with just during this pandemic, as examples we can give, we had worked with the United Way and another group whose name is escaping me to help provide technology and internet to folks who are living in more rural or just due to their incomes weren't able to access those pieces to stay connected. We've been working with Peers Alliance, just to revisit that one, in terms of support for youth who are kind of all across the island and wellness in those areas. We support about 30 different self-help groups across the island that are usually run by volunteers. So we help to provide them with administrative support in that. We are networked in with the libraries, with public health as best we can to support their initiatives. And then our other kind of more frontline staff would be doing a lot of work with the shelters and the food banks as they do support around housing and basic human needs. Those are just the ones that are coming to mind right now, but there's a bunch more depending on the kind of circumstance.
And like I said, so we work kind of hand in hand with the McGill Center or Richmond Center. They'll send referrals to, well, that's what they're currently doing right now, is sending referrals to us because they have a really long wait list. So we're seeing the peers while they're on that wait list, which could be up to like a year sometimes. We also work with PI Rape and Sexual Assault Center, Anderson House, Blooming House, Lacey House, and I'm trying to think who else. So I'm trying to think.
I feel like I need like my list in front of me.
Quite a few organizations. Collaboration is key for sure.
Hannah?
Thank you, Chair. Yeah, and those are very familiar organisations. I think, to us, so we talk about sort of the Upper Room Food Bank, and they said all the different shelters. You've probably got things in there like Salvation Army and Deacon House, and I think I mentioned Peers Alliance, Boys and Girls Club, Rape and Sexual Assault Centres. Every one of those organisations are under the social development umbrella right now. I mean, things move around, right? But they fall under the umbrella of social development and housing. And during our work a couple of years ago on poverty, there was a poverty action plan, and one of the commitments in the poverty action plan was that the community sector network needed to be recognised as a sector. It needed to be funded with multi-year operational funding. Because we needed to recognise that if we're going to download the work of addressing, in that case, poverty, which obviously is a kind of a crossover in our continuum for mental health, that we had to do that by acknowledging that partners needed to be at the table, not just in decision making, but financially funded to do that work. We still don't have a minister responsible for the community sector. It sits underneath that umbrella as one of the many things. We asked for funding for those organisations this year, and there was a commitment that they would get funded. That money hasn't gone out the door yet, even though it's the end of September. But those organisations have still been showing up and doing that work anyway. What I know, though, is that what that means is that for some of those organisations, when it came to doing an operational plan, that's somebody sitting in their living room doing that as a volunteer, unpaid. And there's only so long that will go before people in that space burn out too. So my point on this is, to me, in the continuum, I recognise my colleague's point around mental health as a ministerial space, as a responsibility. We have that responsibility under our health space. I think we can argue about shells and games, but there is absolutely a need for us to honour that commitment to the community sector network, because without them in this thing, all of this falls apart. They're the foundation that everything else is sitting on, and they're just as much at risk of burning out and falling over as probably as you are, Courtney. Are you seeing that in when you work with your partners? Because we're concerned for you and your health. We're concerned for the health of the people that you're supporting. What about the partners that you rely on? How are they doing?
I'll go ahead. It's a rough time for everyone. Everyone who is on the front line of this, who is working with people on the ground, who is trying to continue to pull resources out of thin air, is struggling. And I think because people don't get involved in community level work for the paycheck, that's not usually the motivation why someone ends up in a nonprofit. Their passion for the people is what's going to drive them forward. And so yeah, I think we would see, even with our own organization, that we have to be really intentional about not overburdening people, because they will go as far as they possibly can. And I think we see that within all helping professions, but especially within community level organizations. I just want to pick up on what you said, Hannah. So we sat on the poverty reduction development team, and I think the strategies and the action plans that have been developed in the past by the government are still relevant. All of those documents and the suggestions that are in there, those action items still stand firm. And so it might be useful to revisit those and to pull them out again, instead of trying to recreate those solutions that people have been poring over for years. Some of those answers are already there, and some of those answers could be acted on very quickly to make a pretty substantial difference.
No, I really appreciate. Thank you, Chair. I really appreciate that. That's exactly we've got fantastic work that was done to identify those, but with those actions remain, as documents and not functional, and it doesn't mean that we can't do more than one thing. We can improve our focus and response from a healthcare perspective, in whatever that may look like. But we also have to fill that other gap, because otherwise, we're top loading on without that solid foundation. And those findings from that really good work that was done around the Poverty Reduction Council, and all of the the stakeholder input were really critical to us moving forward. And when we look at where some of the gaps are, it's because some of those things haven't been done. Yeah, so I agree. We don't need to go and talk about that again, except in terms of why isn't it done yet. Which is what I do. So when it comes to there have been questions asked before about sort of the Canadian Mental Health Association and being a national body, but also a provincial body. How does that reflect in the work and the decision making that you do? So you get to access sort of these larger pieces like this that are done on a federal level, but how much autonomy do you have in terms of that sort of provincial response?
Yeah, that's a great question. So we have a lot of autonomy. We're able to target our services and make decisions for what we do in terms of delivery here on the island based on the needs that we see, with the benefit that we're connected to not only the national organization, but also to other jurisdictions across the country who can provide information to us. So for example, we just launched, and each of you received a copy of it, Courtney had mentioned it, the Cmha PEI Learning, Training, and Support Hub. And that's where we are trying to pull together useful courses to promote mental health and build resiliency. And we've actually partnered with the Cmha in Manitoba to be able to deliver that model. So we have a lot of autonomy here. And then we also nationally have initiatives that they are working to champion that will affect islanders. So as an example, Cmha National is working with Bell through Bell Let's Talk Money to fund a bounce back program that will be launched for all Canadians. So islanders will have access to this service, which is a telephone CBT service that they can access for free. And it doesn't require, at the moment, it doesn't require doctor referral. So folks can actually just get themselves in line right away. With the idea being that National wants to provide the almost the pilot information, show the data that it is effective, so that provinces can then make the decision if this is working well enough for them to fund on a provincial level.
Hannah?
Chair, my last question in this round was, I know the United Way has been a partner with government as well, kind of, I think of it as different levels, kind of that top tier level, and their role has been, most recently, among many, has been around the 211 service, the Navigator service, which I've heard really, has been really effective, because one of the challenges is not knowing who to call, like how do you begin to find it? How has that, where's the integration for you in that service? Is that something that people can get to, for instance, to get access to the peer support program?
Yeah. So 211 has been lovely. We've worked really closely with Andrea at the United Way, as well as with the 211 operators, the info putters. I'm sure there's a more official title than that. They have been lovely in terms of seeking out information from us and figuring out how to best populate that data. So we know that our pages are well taken care of. And then connected to us, they've been really good at allowing us to promote community groups that wouldn't necessarily have administrative pieces to be able to do that. So as I mentioned before, the self-help groups that function across the island, we would be the ones who are advertising for them under our Cmha heading. And so 211 has been really, really great to work with on that front. Yeah, and I think, yeah, I know your number is listed because we gave it to them last week. That's
No, thank you, Chair. That's great to hear. I know it really was one of the things that we've heard, I think, from a constituency perspective, it's one of the most challenging things that the average Islander has is how do I even know where to begin? And I know the Helping Tree document is, functional but terrifying. So having another route that it doesn't require you to be able to get your magnifying glass out. And in times of crisis, frankly, that's not kind of the best route. So no, that's really great to hear. No, thanks for the update on that. Thank you, Chair.
So committee members, we have about another 15 minutes for
Yep.
questions, and then we'll take a 2-minute break, and then the next presenters will meet. Brad Trivers.
Thank you, Chair, and of course, thank you presenters for coming in, Tayte, Courtney. It's such an important topic, and wearing my Minister of Education Lifelong Learning hat, of course, we see that how important it is to have kids back in school, students back in school, both to the students and to the parents, right? And we've seen that from organizations across the country, like the Sick Kids Hospital in Toronto, saying this needs to happen. There may be some risks on the public health side, but the rewards, from the mental health and wellness perspective, far outweigh those risks, and that's all fed into the decisions of the public health office as well as the department. So, and then of course, you mentioned how many people are impacted when they're at home, and it can be things like the lack of food. And so we were really glad we were able to partner with Social Development and Housing to provide food to people during the lockdown, so that provided some sort of physical supports. But as we've heard, the calls to the kids helpline went up a huge amount, and that's why it was so important to get kids back in schools. But one thing, when I talk to people that have experienced mental health issues and come through it or continue to struggle, they often say that they want to give back. And they talk about how important the self-health groups are. And I just wanted to, again, give a shout out, as we've heard already, to Courtney and people like you who do that. And I wanted just to be very clear about if there are people that want to get involved and want to give back in that way, or if they're looking for a self-help group to be part of, should they call your individual and family support line? Is that the best way to do that?
That would be the best line to call, and then we'd be put through to peer support.
And peer support, these groups, sorry, Chair. These 30 groups exist across the province, right? Good. So my second question, you talked a lot about community supports, and we heard Hannah talk about NGOs, right? One thing I know is there's people who are volunteers in service organizations like Lions Clubs, like volunteer firefighters, and of course we know volunteer firefighters often experience PTSD and things like this. But I find that quite often their involvement as volunteers in those organizations is a way for them to have a more informal self-help group. That's connecting with people, that's a social connection, that's that self-esteem, it's validating themselves. And the other group that I find people really connect with, although it's more of a traditional way, I guess, of that connection, would be churches, right, throughout the island, and especially in rural areas. I think the churches are stronger, maybe not, maybe it's across the island. But I was wondering, from a community supports perspective, do you have connections with some of these service organizations, volunteer firefighters, Lions Clubs, Knights of Columbus, and just churches directly themselves? I myself, I'm a member with United Church, and I find that's one of the things that I get when I benefit from the church community, is that social interaction and that self-esteem, and so do you connect people with those, or do you provide training for people in those organizations for that sort of self-help?
You can go.
Yes, we do. Yes to both. Yeah, we do have connections and would network in if it was an appropriate connection to make. And then we do also offer service or opportunities for training because we recognize, to use like a cake boss analogy, if we don't have that solid bottom layer of the people who are actually able to recognize that help is needed, they don't have the tools that they need to provide at least the connection, then people are going to fall through the cracks. So as one example, right now we're working with Living Works, which is a international organization that provides suicide awareness and alertness and intervention training. And they've actually recently developed a model specifically for faith-based communities so that their parishioners can provide training or receive training to be able to identify thoughts of suicide within their members.
Brad?
And just to be 100% clear, and, just for the record, as it were, so if there were individual churches or individuals within churches that are interested in that, or the Lions Club, if that was something they wanted to take on for their community, would they call that individual and family support number? Is that the best way?
Yeah. That number goes right into my office. We will work with anyone. Anyone who wants to give us a call, we will happily take their phone.
Thanks again for your work, and I think it's incumbent upon all of us to get the word out that those supports are there and that people know those numbers to call as well. I know as an MLA, that's one of the things that people want to know. How do I get support? So I think we need to continue. So thank you, Chairman.
Thank you, Brad. Heath?
I really don't have a whole lot more. It was something that Corey raised, and the beds at the hospital, I remember when those beds went there, and I think the atmosphere around that was mental health is an illness. And it's kind of like the bell talk situation and so on and so forth. And I think that's really, Corey raised a really good point on how important those beds are to there. And then you raised the points relative, Courtney, to the system that's in place when they are there. And I think that's something that this committee really should focus on too, is maybe getting those beds back into those hospitals. And I think that's important. But I really don't have a whole lot. I think I agree with what Hannah said, what everybody said in this side, and I think it's extremely important. I think there's a lens on it, and I think it was Dr. Tedros from the World Health Organization said the next pandemic is mental health. So I think if any politician is got the blinders on this, they're likely in the wrong business. So if anything that we can do for you as a committee, I think we'll all join hands here and do it pretty well. Maybe not social distancing, but we'll certainly do what we can do for you.
Great, perfect. I'll just ask you, what are we doing? Are we doing a good enough job when newcomers or people of color come to Prince Edward Island to support them with their mental health concerns?
No. No.
Do you want to speak to it, or?
No, well, just that we do receive some referrals, and like a lot of times they just tend to fall through the cracks, and if their language barrier, if there's an issue with that, they just seem to not be able to get services that they need. So yeah, we do see that.
And I think to add to that, we see it happening in a bunch of different avenues. So we know when folks are arriving in PEI, there's a lot of misunderstanding and myths around how accessing healthcare actually works, let that be physical or mental. But I know I've had conversations with students who are at the university who have been told that if they call a helpline, then their visas will be revoked, which is not true. That's not how it works. But they've been told that. And so there's a lot of misinformation in terms of accessing service. And then the service that they are able to access isn't necessarily appropriate for what they need. So we had a number of folks reach out after George Floyd's murder asking for service provided by people of color and Indigenous individuals. And as far as our networks were able to figure out, there just isn't a lot of options on the island to be able to speak with someone who have that shared lived experience in a clinical setting.
And I asked that question to set up my next question, and it's around the situation that happened and that's happening with Trayvon. in Charlottetown and Prince Edward Island, when he came, did he get the services? I mean, there was a lot of different things that happened in his case. I understand that, but are you familiar with anything to do with his situation at all?
Loosely.
Yeah. Were you guys contacted at all to assist him in any way possible?
We were, I can't, for confidentiality, I can't give too many details, but we
Yeah.
were contacted for information that would not, more so around the condition of care and possible resources that might be available.
Yeah. And I just, it's clearly there was mental health issues that kind of is kind of what we're talking about today. If we don't get there quick enough, bad things happen. So I think that we're kind of on the right track here. We have health PEI coming in next. If there was some questions that you would think of that we could ask them, what would they be? Not easy.
That's not an easy question.
Or what would you want to tell? What would you want us to let them know?
Just about peer support and the benefits of peer support. And if we were be able to work in the hospitals or just go in and visit, because sometimes people are in there for months at a time and they have no visitors. And they do nothing every day, and that's not going to help. So if we were in there or visiting more often, able to visit more often, then that would help. And yeah, that's something I would suggest.
Great. Yeah.
And I would personally, I would commend the nurses and the staff who are frontline right now within our services. Having met with them before, they are working, they're working really hard. And I think that's often overlooked, as with any service, but they're working really hard for the majority of cases to do the best that they can. And so I think my question to them would be, what do they need from us? What can we do? Knowing that we, as a nonprofit, have a little bit more flexibility and nimbleness in our reaction time. There's a little bit less red tape for us than there is for everyone else. So I would want to know how we could be better integrating our service and support them better.
Great. You did a very good job. Is that okay with the committee? You did a very, very good job today, and I think it was a very powerful presentation. So we're doing a report to the Legislative Assembly in November, and we'll be sure to include some of your key findings here in that report. So at this time, we'll take a 3 or 4 minute recess, 4 or 5 minute recess, and then we'll be back with our next presenters. Thank you very much.
Thank you.
So we're back for the second part of our meeting. So we have Health PEI, Dr. Heather Keizer and Verna Ryan are here to present. So we'll pass it over to our guests to get things started, and we're looking forward to your presentation.
So thank you very much for this opportunity. My name is Dr. Heather Keizer. I'm the Chief of Mental Health and Addictions. And in Gord's invitation, he suggested I might bring other staff, other individuals who might be helpful in the presentation. I'm bringing Verna Ryan, our Chief Administrative Officer, who's been very involved in really operationalizing a lot of the ideas and the plans. And I guess I came to this having read Gord's invitation to explain some of what has happened during COVID. Lots has happened, and also to be available to you to maybe provide more in-depth understanding of our services and what services hopefully are going to continue as we move forward. So I wanted to set the stage a little bit for you. Some of you were at our previous presentation to this committee, which went on for 4.5 hours. We don't plan to do that today. But in that particular presentation, as I think some of you will remember, I think Honorable Trivers would remember our presentation, we went into a lot of depth about not only our services as they stood, but also as we hoped they would become within the next 3 years. Currently, pre-COVID, that would be in February this past year, we were offering outpatient services, for mental health services. That would be non-psychiatric services as well as psychiatric services. We offered addiction services both at Mount Herbert and also in Summerside. Inpatient mental health services, that is psychiatric services on Unit 9 at QEH at Hillsborough Hospital, as well as in Summerside, Prince County Hospital. Before COVID, outpatient psychiatrists, we had 3 FTE psychiatrists in the West. We had 4.8 FTE psychiatrists centrally. We had 0.4 FTE psychiatrists East, and 1.5 psychiatrists were doing telehealth. Now, actually, it was really more like 1 psychiatrist and there was 2 people filling 1 FTE. So one person was doing 0.5 child and adolescent psychiatrist as an outpatient, and 1 psychiatrist was doing 0.5 FTE as an inpatient psychiatrist. Inpatient psychiatrists at the time, right before COVID, we had 1 psychiatrist working in Summerside. We had 2.4 psychiatrists working at Hillsborough Hospital. We, right before COVID, had no one on Unit 9. The psychiatrist who was there was going to be done at the beginning of April, and we were going to have no one, and no one planned to be there, which was a bit frightening. That's why there's an asterisk on that one. And we had 0.5 psychiatrists doing inpatient child and adolescent psychiatry on Unit 9 at that time. The wait time before COVID was 150 days at least for a child to be seen. If they were not severely ill but needed an urgent assessment, it would take about 150 days for a child to be seen by a psychiatrist. The wait time to see an adult was at least 350 days, and that was across the system in Montague and in Charlottetown. Forensic psychiatry was very difficult to deliver, and it was taking up to 60 days and more to get a forensic psychiatrist to see assessments. But our master planning was underway and moving forward, and a big plus right before COVID was that in January of this year, it was passed that we would be allowed to increase the complement of psychiatrists to meet the demand, which was outstripping our supply, to 20.8 psychiatrists for the province. So, whoopsie daisy. This is a map of where our services are delivered. Maybe, Verna, you might want to go into some detail on that if you want.
So just to give you context in terms of what our services are and what they look like across the province, we have services from Tignish to Surrey. We service children, youth, young adults, and seniors. And we have community services through to acute care services, both for mental health issues and addiction services. So we have in community mental health and addiction services, we have walk-in appointments, which we've implemented to increase access, through to regular therapeutic groups and sessions, and also seniors outreach teams. So actively working with seniors in the community and in long-term care, community care facilities to deliver services to them. We have inpatient services, treatment services like the Strength program. We have long-term recovery homes, St. Eleanor's, Talbot, and Lacey House. And we also have student well-being teams. So the student well-being teams, social workers, and nurses fall under mental health and addictions. Our addiction services include the Provincial Addiction Treatment Center, PATF, or Mount Herbert. We have a partnership with Queen Street Methadone Clinic and deliver our what we call our opioid replacement therapy program there. And the community mental health centers are at Richmond Center, McGill, Montague, Surrey, Alberton, Summerside, and then with satellite offices in Evangeline and in Tignish. We work closely with primary care, and so we actually have collaborative care, which is our staff working with the staff in family doctors' offices so that it increases the capacity to deal with mental health and addiction issues in the community. And our acute care mental health, we have, as Dr. Keizer mentioned, a unit at Prince County Hospital. We have Unit 9 at the Queen Elizabeth Hospital, and we have Hillsborough Hospital in Charlottetown. And to come, we have crisis response.
We'll get that maybe again.
Pardon me? Okay, but we'll get to that.
Hopefully we'll get to that at the end, but yeah, go ahead, say what you're going to say, that's important.
So community mobile crisis response is a new initiative that will be underway this fall.
Okay. So when COVID hit us in March, this was our task, and initially, so mental health addictions wasn't included in the joint response team. So, but we still had a task before us, and we still had to deal with operations. And I participated as part of the medical directorship from Hillsborough Hospital, for instance, in terms of what we had to solve and what we had to deal with. So we had to prepare the hospital sites to potentially treat high numbers of COVID-19 patients. We needed to keep as many people as safely as possible at home and away from hospital if it was possible, to keep as many people as safely possible away from the clinics and away from the ERs. At that time, that was we were very concerned about infection, and to keep our patients and our staff safe. And this was sort of, as I saw it, my mandate as we move forward. And I took inspiration from Dr. Richard Malika. I've trained with Dr. Richard Malika in global mental health. I've participated in the Global Mental Health Action Plan most recently in 2018, and have been a consultant to, say, the Gaza Strip with regard to interventions for addictions issues there, as well as doing some consulting work for China because of my connections to the global mental health. And so in this group, we all had way more work, mind you, PEI is a little smaller, way more work, way more demand than there was supply for mental health services internationally. And what Richard would always say was, do what you can where you are and start there. And so that's really, we embraced that. So we had a number of challenges, and these were our challenges. All our psychiatry services were deemed essential, which they needed to be. The patients could not go without ECT treatments or medication injections without becoming severely ill. Now, not all of our patients, but our severely psychiatrically ill patients must have regular treatment, otherwise they might become severely ill and put themselves at risk or put others at risk in the community. People with addictions could not abruptly stop alcohol without potential risk of death. There's a risk in Prince Edward Island alone, a risk of 40 to 100 people could have died within 3 days had they had abrupt discontinuation of alcohol access, which would have outstripped anything we would have seen with COVID. And finally, our patients are very typically, although not stereotypically, at high risk to acquire COVID because many of them have comorbid COPD, comorbid cardiovascular disease, low immunity, and then also issues around poverty for many with crowding. And so, and also difficulties in accessing information. So we saw our patients at really as individuals, especially our inpatients, who needed protection from COVID as much as possible. We had physical challenges. So as you're aware, we are building and planning to build a new Hillsborough Hospital, but the current current Hillsborough Hospital is not so wonderful from a physical perspective and could not, we felt, accommodate any COVID positive patients. So when we were doing our planning, we had to recognize that there were no medical lines for oxygen and whatnot at Hillsborough Hospital. There were no sealable doors, so we couldn't have a separate COVID unit like they were able to set up in Nova Scotia. And Hillsborough Hospital carried many high-risk patients. So we had geriatric patients there, dual diagnosis patients, that is patients with cognitive delay who were confined to their beds, some of them. And then we had acutely ill patients who were very erratic psychologically and psychiatrically and behaviorally. And then the PICU was our psychiatry intensive care unit, again, housing individuals like you would see in an incarcerated setting for containment for short periods of time, not unlike the jail. So these people all were at high risk to get COVID potentially and be sick. And so again, they needed protection. And then finally we had a challenge with regard to QH because the QH was deemed the COVID hospital. They needed more capacity. And so that was an issue that we had to address as a challenge as well. So these were our solutions. We discharged as many people as possible to be followed up at home from away from the hospital with clear safety plans. So as many patients who could get discharged from Unit 9, as many patients who could get discharged from Hillsborough Hospital, as many patients who could get discharged from Prince County Hospital were discharged home with safety plans with follow-up in the community. We established and fought to establish Hillsborough Hospital as a non-COVID ARC for our patients and staff, where no COVID positive patients would be admitted and patients would be protected from exposure. So we made, because it couldn't be a facility to medically deliver COVID treatment, we made Hillsborough Hospital into our place of safety. Away from COVID, and so we restricted, it was designated, fought to get it designated as a non-COVID facility, and then we moved as many people, our staff and our patients, into that facility away from any potential exposure to COVID. And then we maximized the clinical potential of our psychiatrists, who many of whom were over 55, by embracing telehealth. And this was a huge step forward for us because I think many psychiatrists were very nervous of it, but we really embraced this to get the most out of our clinicians. And then it was subsequently embraced by our mental health staff as well. So how do we do it? Our teams met and organized immediately as soon as the announcements came out about how we had to have a response. The psychiatrists began meeting daily, every day during early COVID, probably from March until the end of April. We initially met by telephone, and then eventually we met by Zoom. And so I was able to coordinate the discharges and put together plans with my colleagues immediately. We immediately did inventories of our physical space, what capacities we had within our facilities, and we also did an immediate inventory of our human resources, and we tracked where all our staff were, whether they were employed either between Hillsborough Hospital and long-term care facilities, and we tracked everyone so we could track who was where, so again, to protect them against infection. And then we met daily as management groups to share ideas and to try to creatively formulate plans, because we, again, had very minimal space. What are we going to do? And we engaged IT immediately and took full advantage of the process mapping with corporate services. So I would say it was within days, actually. We decided that we needed to make more space at Hillsborough Hospital, and so we decided we would transform the transition unit at Addiction Services as a place to take our ALC patients. And that took enormous effort, not only with IT work and process mapping, but actually physical change. We had to make that a safe location. Maybe you can give some examples, Verna.
Sure. So we were looking at fixtures, non-ligature items within the unit, taking things off the wall that were breakable, and we also reduced the number of beds so that there was physical distancing possible. So those would be some examples.
So what else we did, this is the ALC patients. So the ALC patients are patients who are alternative level of care. So they might be a patient who, for instance, has a working diagnosis of schizophrenia, has come in very discontrolled, very distressed, is started on medication, stabilizes, but is in fact without a place to go. Maybe their housing situation is broken down, and so would choose not to discharge them to the street because that will just make them vulnerable. So they would be awaiting maybe an admission to a community care facility, or maybe they were awaiting approval for funding for an apartment. And so they used to stay with us at Hillsborough Hospital, and so those those patients who are medically stable were moved out to addiction services, and then that unit where they came from was able to accept patients from elsewhere. So accept the patients in from who, there was actually only about 3 patients who were left on Unit 9 after we had our discharges, but then the psychiatrist came with them. So the psychiatrist from Unit 9 came into Hillsborough Hospital. He was an every day of the week psychiatrist. That was, he did that full time, and the psychiatrist who worked with the ALC patients was only there like a day a week. And so he moved out to the addiction services. But then when addiction services closed out the overnight transition unit, then we had to have solutions for that, which Verna did.
Sure. So we moved the transition unit program under Lisa Thibault, and we took up in one of the schools in Charlottetown, where again the CPHO guidelines could be enforced, and we maintained that program. I think there was a 2-week gap while we're getting that set up, but from then until the end of August, that program was maintained in the community.
So one of the things that was working for us was that as COVID rolled out in March and April, the demand for our services went down. And that was helpful because that allowed us to start to transform our service as well. So the demand was down, that gave us a little bit of breathing room to start building our capacity. So we did. Another thing that was just an advantage, and I didn't put a note about this, was the psychiatry complement. So as the chief, one of my roles is to actually make sure we always have psychiatry coverage for all our units. And I had been in an incredibly difficult position with no psychiatrist to cover Unit 9. But COVID saved our bacon. For a number of reasons. One, all my psychiatrists who had booked all these nice exotic vacations canceled all their vacations. So no psychiatrist went on vacation, so I had everybody. And the guy who was here was going to leave the 1st of April because his family was in Quebec. Quebec was a disaster. He moved his family to PEI. His child was born in PEI. He's now here. So he's actually chosen to stay and sign a contract with us for the year because we became a place of safety for him. So that was pretty cool. But then we still had the problem of a huge demand on the emergency rooms and a need for space there. And so we came up with the idea of having an urgent care clinic that would take a portion of the patients who didn't need safety and who were not, say, psychotic or violent, away from the emergency room and be seen elsewhere by a virtual psychiatrist and assessed and could maybe be admitted directly from there or discharged back to the community. So again, this work moved very, very quickly. We started the work in mid-March, really right away, and we were up and running by the 1st of April. And so by the 1st of April, we opened a psychiatry urgent care clinic at Hillsborough Hospital. By April 6th, we opened one at Prince County Hospital. And it removed actually 40% of the patients, psychiatric patients, from the emergency room away from the ER, gave them some breathing room, and actually gave good service to our patients. I'll get into the outcomes in a bit. And then the other thing we did, we were all worried that the psychiatrists would get sick because they're old, and we set up telehealth capacity within Hillsborough Hospital so that if, say, one of our 2 psychiatrists in Hillsborough Hospital got ill or was worried about exposure, then we would somehow be able to deliver that service anyway. All the psychiatrists, within probably 2 weeks, I directed them all to set up home offices with fax machines, and they began immediately delivering patient services at home. They were able to fax in all their prescriptions. They telephoned patients in their home, and really very, very quickly, Health PEI was able to give support to get us on Zoom. So we were able to do Zoom Healthcare, which is a secure platform. So the psychiatrist could interview patients face-to-face by Zoom on patients home with their telephone. The psychiatrist is on a computer and able to do those Zoom healthcare assessments of patients in their own homes. And all the psychiatrists were then also put on Cerner with VPN, which meant they could access patient charts, they could admit patients to hospital, they could call the pharmacy, they could fax in prescriptions, or they could just call in prescriptions. And so that happened very quickly, and it worked really well. The interesting thing to me was probably within a week of having telephone conversations, we have a psychiatrist in our ranks who during our first 3 weeks of COVID had his birthday, so we sang happy birthday to him over the telephone. And he was the same psychiatrist who said, we need to be on Zoom. We need to be on a virtual, and so it was actually our oldest psychiatrist who pushed us all to do this, which I thought was pretty cool. Another innovation was that our child and adolescent psychologists stepped up and they set up telehealth assessment service to complement the work that we were doing in the psychiatry urgent care clinics. Maybe Verna, you want to talk about that?
So this was a virtual service that was set up. It included psychologists, social workers, nurses, and youth workers from some of our child and youth programs that had to move to a different way of delivering service during COVID. And they had quite an advanced assessment process to receive calls from children, youth, and their family members. And over the course of this service, they saw 48 or dealt with 48 quite acute situations, and they dealt with a further 36 that were not as acute. So this really gave people a service locally, and they were prepared then as well to see someone if they had to, if they wanted to come in. But during that time, really the phone service was preferable for most people.
Our outpatient services continue to deliver individual and group therapies by telephone, Zoom, and by WebEx. Now, WebEx is sort of a hardwired, it's a different platform. In the hospital setting, we particularly tended to use Telemerge, which is hardwired. I myself delivered group therapy and have delivered group therapy by WebEx. It's been quite interesting. 3-site group therapy, it's pretty neat.
We had walk-in clinics established, and I think it was March 20th, we were opening a walk-in clinic at Addiction Services, and immediately those all went to call-in clinics, so people could call in at any point in time, and all of our therapists and clinicians in the communities were set up on Zoom right away and delivered, as Dr. Keizer says, groups and individual sessions throughout this period of time.
And then probably, I guess, getting on the middle of April, we set up a virtual psychiatry assessment service. And what this was a service whereby, because all our psychiatrists who are licensed on PEI could deliver service virtually, and I had a number of psychiatrists who had been doing tentative work with us who were in Ontario. I had one who joined our ranks from New Brunswick, one who had signed with us from Ontario, Kitchener, another one who signed with us from Quebec, and we looped around, and they actually increased their service to us because there wasn't so much going on in Ontario with virtual care, so they ramped up their service to us. And we were able to hire up our admins and set up a mechanism and able to start seeing the backlog of semi-urgent adult cases and children's cases, as well as new referrals. At this time, right before COVID, we would have been receiving about 40 new referrals a month, 30 of which would be adult, 10 would have been child and adolescent referrals. And so when we set this up, we prioritized the new referrals, but we started working on the backlog of referrals that we knew had been a problem for us. The psychiatrists began delivering on-call services in the ERs and the PUCs by telehealth. So we also got pushed and got capacity to do telehealth in the emergency rooms of Prince County Hospital and Charlottetown Queen Elizabeth Hospital. And I had to set up a roster to support that, but nonetheless, the psychiatrists on call now could do call from home. And what that allowed us to do was, as we had signed on these new telehealth psychiatrists to do assessments, some of them could do call for us too for the very first time. So we had psychiatrists on call who were living in Ontario who would see a patient by telehealth, could write a prescription, they were licensed here, and if perchance they needed to have a feet on the ground, they would call me and I might go see the case. But really we delivered quite a few on-call service nights with no need to have somebody who is physically present in the province. And that was a huge innovation for us and very helpful when we've had a lot of restriction in our call schedule. And Zoom and telephone appointments were expanded to support long-term care facilities and community cares because we got access to like iPads and whatnot for those community service areas, and we're able to deliver, say, seniors psychiatric assessments in the seniors' homes that were locked down because those patients were in distress. So, outcomes to date. Cut to the chase. Patient satisfaction with the psychiatry urgent care clinics was extremely high. They felt that they were heard. They shortened the wait times. Various numbers on that, but it certainly cut them in half and maybe by more.
By more, I think the average wait times prior to this would be, for someone going to emerge, would be at least 29 hours. And in our experience, it was down, the quickest one took 52 minutes. And that means they were in front of the clinicians, in front of the psychiatrists, and on average it was 4 hours wait time at the urgent care clinics, and that's what continues.
The on-call psychiatrist roster is obviously expanded because we had more people who could join us. Outpatient mental health and psychiatry services remained intact. We really were able to maintain our service throughout. And this is where a huge win came. The outpatient wait times for psychiatry with that virtual psychiatry service dropped from 150 or so days for children to 7 to 14 days for adults and children in July, and currently they're at 14 to 28 days. So I'm just going to remind you where they were before. They were 150, 350 plus, and 60 days to see forensic psychiatry. Now, we have more psychiatrists because we recruited that fellow who stayed, and now our wait times are 14 to 28 days for children, 14 to 28 days for adults, less than 15 days to see forensic psychiatry. And we've continued on with our master planning remarkably throughout COVID. So, observations and challenges going forward. We noticed that the demand for mental health and addictions admissions went down during March to May. Patients felt safe with telehealth. Contrary to many people's concerns, they were very happy overall and safe with mental health. And that was even true for older patients. Addictions concerns were unmasked and escalated. We saw a real rise over time in people presenting with psychosis secondary to marijuana use that had already been a bit high, a real rise in alcohol use and people presenting with alcohol psychosis, but also just in distress and withdrawal issues, and with crystal meth. I really noticed crystal meth actually over this period of time too, unfortunately, and opiates too. I would note that troubled families had increased troubles. I don't know if you want to comment on that, Verna, because you've hosted a lot of intervention around that.
Sure. So one of the things that we did as part of our screening tools when people would call either our information line or coming to the urgent care clinics or any points of contact, so we have many screening tools that we use, but we added in one around relationship stress and family violence. And we were also part of a interdepartmental committee that was monitoring family violence, just because we didn't have the usual checks and balances through schools and other points of contact for families and children and youth. So we didn't see huge numbers there, but we were glad to have that information and to be able to feed that into the larger picture and for our own service.
I'll comment. I noted Gord's question to our previous presenters, because as you know, contiguous with COVID, we also had the Black Lives Matter movement, and I would say that there was a lot of comment on Facebook that we got. I didn't get a lot of direct requests, although we communicated, and it has been an ongoing concern for me around that. So in the midst of this, I was actively recruiting for diversity within our ranks. If you noticed in my bio, I have been on, weirdly, as a white woman on the committee, but nonetheless, a representative on the Indigenous, racialized, and refugee populations action committee for the Canadian Mental Health Commission, and that's partly because I've trained in refugee work internationally, and I was interested in it. So I have, but it is. I appreciate the limitations around my capacities, having lived experience and not being someone who represents the patients who are seeking help. One of the advantages in mental health and addictions, or psychiatry particularly, has been, in Canada anyway, it has typically been a very diverse population of clinicians, and almost always we've had diversity within our ranks, both religiously but also with regard to ethnicity and culture. That is perhaps less true today than it was when I first came here. And so we're not there yet. And I would say with our delivery of our services from the frontline staff, we may be similarly not as representative as we would like to be. I think that's a point. So I note that because it was on my mind at this time when we were talking about the stress in families, and particularly new-coming families. So projected needs. We need to stabilize our service from crisis mode to sustainable mode. It has been exhausting. Our staff have worked so hard. Many of us, particularly early in COVID, were working 18-hour days. Everybody put a lot of effort in, and now to pull back again has been hard, and then ramp up again, and it's been really exhausting for people who are already doing highly demanding work. And so we really have to appreciate the concept of compassion fatigue, and that people do need to be supported, not just our staff, but also families and physicians, and compassion fatigue is an issue that we really need to address, and we know that going forward. The other thing that we truly appreciate at this juncture is the shortage we have of nurses, LPNs particularly, but also social workers, psychologists, and physicians, psychiatrists. And we need to map longer-term pathways for with predictable contingencies. So if this happens again, what will we do? And because really a lot of what happened for us was very organic, and we were making decisions on the fly and then having to pick up afterwards, which was really very tiring for everyone. And in future state, it would be nice to know what the contingencies are going to be, as opposed to making them up as we go. Projected needs. We need an appropriate and safe place for alternative level care patients away from acute care beds across the system in Prince Edward Island. This is not just about mental health addictions, because currently ACL patients occupy medical beds, surgical beds, rehabilitative unit beds, and Unit 9. And we need an appropriate place for them to go. These are people who shouldn't be in hospital, they're not acutely ill, but they need a place that's appropriate for them. And we need to look at the establishment of a restorative care unit. I know this has nothing to do with mental health addictions, but it does. We need an appropriate and effective restorative care unit to facilitate the transition of non-acute patients back to appropriate community placements, because all the dominoes affect one another. The patients currently sitting in Unit 9 are ALC, who need restorative care, who need to be in long-term care facilities, or they need to be in home care. And so we can't accommodate the acute needs of psychiatric patients while those people are there, but those people need to go someplace safe too, that's not going to get them infected with COVID, and it's going to give them appropriate support. So it is a very complex problem-solving exercise, and it has very practical fallout if we don't do it in an appropriate way. We need to recruit some more family doctors. Our team was full on, they were so creative that by the time we were at the end of July, they were still putting together projects. And so we knew that there was a rise in addiction services needs, and so our team put together a plan to have outpatient detoxification programming, and it was ready to roll, frankly, in July. We put it off until the end of August, ready to roll in August. No doctors. And that's unfortunately, not unfortunately or fortunately, the keystone to the program working is a appropriately trained family doctor in addiction services, addictions prescribing, who can take medical legal responsibility for each case. And we're really thin on the ground there. So we really are actively working to recruit these physicians. We don't have them just now. And I put PAs there because I'm proposing that we look at physician assistants as well, which is a different classification of clinician, currently not legislated in PEI. Just put that out there.
We do offer outpatient withdrawal programming in Summerside West.
Yes,
so we do have that programming there, but not in Charlottetown currently.
In fact, in a lot of ways, Summerside has led in a lot of innovations and has for a while. But again, recognizing that Charlottetown constitutes about 70% of the demand for the province, so that's a piece too. We're going to need an increase in psychiatrists to do telehealth and admin support for that, and that's because we've been successful. We're going to be victims of our own success very soon. All of a sudden, people know that we're seeing patients within 7 to 14 days initially, and this month our demand went up from 40 referrals a month to 80 referrals, actually 20 referrals a week. And it's going to continue to go up as people discover that we're actually responding well. But that means we're going to have to hire up both admins and psychiatrists. What's interesting about the virtual psychiatry delivery service, we're going to hold on to it, I hope, is that it's very flexible. So I have a psychiatrist, for instance, from Miramichi, works full-time there, but he works for me in the evenings and on the weekends, which I think is pretty cool. All right, we're almost done. We have an urgent need for on-site inpatient psychiatrists. We have 1 FTE per unit. We should have 2 FTEs per unit to meet appropriate standards of practice. So at the moment, we have psychiatrists in Charlottetown. Typically, on an inpatient unit, especially with highly ill people, you should probably have no more than a ratio of 1 to 6 to 1 to 10 for psychiatrists to visit patients. Currently in Charlottetown, the psychiatrists are 1 to 22. So they're pretty tired. It was better when we had fewer patients in hospital. we were at 70% capacity earlier in the year. We have an urgent need for specialized mental health nurses and LPNs. Anyone you know who wants to go into health, please tell them to go train as LPNs. Very, very necessary. And we need an increased mental health training for all the ER staff. I think that sometimes the complaints you might see in the media, Facebook, the perception is that some of the first points of contact are mental health contacts. Sometimes they're not. And we need to do better in terms of and that's what we discovered with the pucks. When our staff met these patients who walked into the psychiatry urgent care clinics, they were satisfied and they felt a sense of respect and treatment with dignity. That same principle needs to be across our system. Enough said there. We need to recruit, I believe, 1 to 2 FTE psychiatrists to be assigned to daytime work in the emergency room 7 days a week. What that would do would give us an ER team continuity so that the psychiatrist could be present and have the same person every day to see the patients and manage it better. I would reduce inpatient psychiatry burnout. I already told you they're seeing 22 patients. So if an inpatient psychiatrist is on call, he has to round on 22 patients plus work the emerge. So that's pretty awfully difficult. And so we would really like to see that change. And also potentially a psychiatrist who worked the emerge would be wonderful support to our new and up and coming mental health and addictions mobile crisis unit. Silver linings. Our innovations with virtual care and mental health and addictions have gained national recognition. I've been invited to speak at the PPF, I don't remember what it's called now, in Ottawa. It's public policy forum about the innovations we've used with COVID. Psychiatrists in Ontario, Saskatchewan, Quebec, Nova Scotia, New Brunswick, and the UK have all wanted to join our ranks. I'm actively recruiting right now. I would have had about 12 interviews in the last 2 weeks. We were recruiting all the way through COVID. We are dramatically expanding our potential to deliver service across the entire island, and our patients have embraced the innovations. And patients have liked it because they don't have to have as much, if we do the telehealth, they don't need as much transportation expense, which I think is helpful. Public and our peers have gained insight into how important mental health and addiction services are to the people of Prince Edward Island. I do think that there is much more understanding. We have I think a fuller understanding of how important this is for all people. Every family has someone who's touched by these issues, and I do think that it's really front of mind for our Department of Health and Wellness and generally. So the take-home message, and this is my opinion, in mental health and addictions, we have done an excellent job in supporting both the health system and our patients during COVID. And our teamwork, creativity, and commitment will guide us to manage the ALC patients, reopen Unit 9, and protect the people of PEI from COVID. That's it.
Well, thank you very much. We'll open it up to questions. Very, very good. Start with Corey.
Thank you, Chair, and thank you both for coming in. Our presenters before, and I know yourself, raised the concern of illegal drug use and the rise in that. I'm just wondering if you can comment further on that.
It's true. It's very challenging. I would say even legal drug use has had a very significant impact upon us in the emergency rooms. In the last 2 years, we've had a significant increase in the presentations with psychosis secondary to substance abuse. We are tracking that. Within our division, we've initiated a new research committee led by Dr. Amanda Hudson, and one of our first projects has been to track the incidence of cannabis-related presentations in the emergency rooms and its impact, because we need good data to really be able to say without question that there's a correlation. But as a clinician who was on call, up to 5 times a month, I would say that I have rarely in the last 2 years had a night that did not have someone present with an issue secondary to cannabis use.
Corey?
At the start, you had mentioned the joint response team.
That's a label, maybe you can talk about it, Verna. It's the administrative response for COVID-19, for Health PEI to respond to the directions given to us by the CPHO, by the Public Health Office.
Joint incident command structure, decision-making body that was between the Department of Health and Wellness and Health PEI.
And you said mental health and addictions didn't have a seat at that table?
No. I think, again, when you think about it, I can understand why that happened at the time. People don't think of mental health and addictions as being an issue with infectious disease. They just don't. But we had to.
Corey?
Do you think you should have had a seat at the table?
In retrospect, I would frankly say that it worked out well for us because it allowed us to really focus on developing services really in an agile way that I think was very helpful to everyone.
Corey?
Do you have a seat at the table now, if that's still...
No. And nor do I think I need one at the moment.
Corey?
So Unit 9 isn't open currently? That's correct.
It's not being used by psychiatry currently.
It's not a psychiatric unit right now. Well, I did explain that.
If you could go into that.
You want me to go into that again?
Yeah, if you don't mind.
Okay. So when we moved our patients to Hillsborough Hospital, the intent was to protect our patients from exposure to COVID. And that was very much the intent from a mental health and addictions perspective. The intent was also to give support across the system for more space to cope with COVID-19. Because I'm not merely a psychiatrist, I'm also a physician who's trained in medicine generally, and I have a responsibility to support my peers in the work that they have to do in COVID as well. And so when I was directed by the lead, Cmha, to get our capacity down to 70%, I did what it took to get our capacity down below 70%. So that's why they moved. And then when that area became open, they were able to take the patients off of the medical units and surgical units and put them on Unit 9 in a safe way, like the wandering geriatric patients. The ALC patients came off of the medical units and the surgical units to give, again, more capacity for COVID response, and were able to be safe on Unit 9. Now, that happened back in March. And at that time, none of us expected that this would be where we sat today. I think everyone expected that it would be ramping back up again, and I don't think any of us anticipated that we would have to be here now, but we are. Does that answer your question?
Corey?
Yeah, I guess a little bit. So you made the point that, well, we haven't had any community transmission of COVID-19.
I didn't actually make that point, but fair on.
Well, you did say that it hasn't ramped back up, so I guess I'm questioning why Unit 9 isn't open now.
Well, as I said, it's full of ALC patients, just like other acute care beds are full of ALC patients, and they need to have an appropriate, safe process to get back out to the community. I mean, maybe you can speak about the work you're doing, Verna.
Sure. So with any of the initiatives that we rolled out, there's an expectation that we're able to sort of expand and contract, right, to match the COVID response or the COVID situation in the community. And so right now, there are, as we review these initiatives, there's some that we would like to keep, there's some that we feel, or have already phased out. So reclaiming the space in Unit 9, we want to be very respectful of the patients that are currently there. Many of whom have dementia and work has to be done with those families in terms of finding appropriate places for them in the system. So that work is underway right now. Yeah, and then we will be reclaiming 12 beds is what psychiatry has indicated that they currently need. So there's a plan in place to move to that later this fall.
So recognizing that there are actually 24 physical beds there, of which previously 20 were adult beds, and all covered by Dr. Masali, theoretically. But in fact, that was, again, as I mentioned, that the ratios are still not good. So ideally, we would be opening 12 beds, because that's probably as much as I can load him up with the hope that in the future state, we might be able to have another psychiatrist come and assist in opening more beds. But for every bed that we open, it's important that you have not only a psychiatrist who's what we call the MRP, the most responsible physician, you also have to have a physical physician who does the histories and physicals and treats the medical illness that those patients present with. That's a requirement of admission. And you also have to have appropriate nursing staff to cover the bed and make sure the patient's safe and cared for, gets their medications delivered during the day and at night. And this is where we've really had a pinch across the system with LPNs and nurses. And so although there may physically be space in that unit, we have to have adequate capacity for nursing staff, for a psychiatrist, for a physical clinician, as well as potential programming. And so we have to really, we're trying to get as much value out of every bed as we can and not cause risk.
Corey?
So I guess is the issue that there's not enough staff, or that?
No, that's not the issue.
Or is it COVID?
So everything we're doing is in the COVID environment, right? So again, we're constantly examining, can we expand our services? Because what we know is that even with COVID, the mental health and addiction impacts are like an echo or a boom that go along with COVID, in increased anxiety and depression, alcohol and drug use. And so there are parts of the initiatives that we want to keep. So the psychiatric urgent care clinic, for example, in Hillsborough, we've had really good results with that, and we'd like to keep that in place.
Or an iteration thereof that's safe.
That's right. And so we're just in the process of looking at the services, looking at the staffing, and creating plans and backup plans. And that's the key for us right now, is flexibility. And it's not easy. It's hard on staff. These are changes. It's hard on everyone. But that's really the environment that we're in right now. The other thing that Dr. Keizer mentioned is master planning for mental health and addictions. And so we've been trying to align any initiative and gather evidence and information on aligning that with the master plan. So one of the reasons we were able to flex this way so quickly was because we had done a very deep dive into our system, its challenges, its capacities. And so we were able to move forward. But we really want to keep aligning with that master plan as much as possible. So it's complicated.
It is complicated.
Corey?
Thanks, Chair. So before COVID-19, was Unit 9 at capacity? Was it?
No, it was, so in the fall last year, 2 psychiatrists ended up leaving, and I had 1 locum psychiatrist, and so we had to close a few beds on Unit 9 because he was getting overwhelmed by the workload. So we shut it down to 16 beds from 20, and that is where we were. But he had given his notice he was going to be leaving in April. But now he's signed a contract and he's with us full time. And so that was a win actually for us. But we're still actively recruiting. Like in the future state, if we have adequate nursing staff, potentially we could reopen all 20 beds. But at the moment, the psychiatrist whom I'm recruiting at the moment to do that probably wouldn't be, initially they said they might be coming in January, they might not be coming till June. And I'm sorry to tell you that, I mean, though I'm interviewing many people, and some people will give a commitment, until their feet are on the ground, they're not here.
Corey?
And so when, I guess when COVID hit and, you know, the whole healthcare system was transforming.
Correct.
So those patients in Unit 9, they were transferred?
Most of those patients were discharged home. So most of them were discharged home because they may have been coming up on the end of their treatment protocol and they were doing well. They would be discharged home with follow-up appointments in the community, follow-up appointments with a family doctor, a safety plan, maybe follow-up appointment with addiction services. But there were about 3 who weren't ready to go home, so they came back over to Hillsborough Hospital with the doctor and the nurses.
Court?
And after, was there a huge need for Unit 9 after COVID hit once?
No, there wasn't, actually. As I said, early in COVID, our demand went down to, we were told to get our demand down to less than 70% capacity in our hospital, and in fact, we were able to do that. It was the first time ever, in fact, in my 15 years in Prince Edward Island, I've ever seen such a low capacity in psychiatric services on inpatients. Really, from March till about May, our capacity was quite low, but now we're starting to see the rise again, and I think Vernon just tracked the numbers, and we're probably on target again to where we were this time last year.
Corey?
Because I know that the demand for inpatients went down, but I'm probably skeptical that the need didn't go away. It's just that people were so afraid at the time to go to the hospital.
So that's an interesting statement, because I actually did a lot of home visits during that time by telephone and by telehealth. And in fact, the need did go down. And it is actually consistent with research that's been done in, hang on. So it's, you don't,
Oh, no, I just have to make sure that in order for everything to be picked up,
okay.
we just...
So there was research done during World War II around the presentation in emergency rooms of people with anxiety disorders, depression, in those days they called it neuroses. And in fact, the presentation of patients went down because patients actually had another focus for their energy, and they actually channeled their energy and actually had purpose early in COVID about safety. And when I talked to patients who might have been, say, socially anxious or OCD, they actually were like, we're normal. We're doing great, because in fact, some of the mechanisms that they used and were maybe considered not as functional generally were very functional during early COVID, and so a lot of people's anxiety actually went down initially. I think now, but it's impacted as well by many other factors, as you well know, economic factors, family dynamic factors, housing factors. All those pieces do factor in, and as we go out in time, and as people maybe lean on coping strategies that aren't as healthy, then we end up with a rise in demand. So we're rising now, but we really early on, I would call people and they say, no, I'm good. So that's not everyone, and certainly we still saw patients. So it's not like we didn't see patients. We were still seeing patients, still admitting them when they needed to be admitted, but people weren't demanding to be admitted when they actually had resourcing at home.
Corey?
Because the presenters that were in before us, they gave us this survey, and well, it was quite shocking.
Survey of a Canadian survey or Prince Edward Island survey? Yeah.
Yeah. But we were all in lockdown for 6 to 8 weeks, right? So I would assume that it would probably be similar province to province, mental health issues. And they had told the committee the need for Unit 9, the programming that's offered there, and they said they would like to see it open.
I don't disagree at all. I do too. No, so recognize we're talking about two things here. We're talking about early COVID, and we're talking currently. I adamantly want Unit 9 back for mental health patients. I said that in my presentation. We need to move the ALC patients off of all the medical units and reopen Unit 9. I would adamantly support that. And the psychiatrists unanimously support that. I don't disagree with that at all. And in fact, I would be advocating for that. But I also have to be considerate of the fact that this, although we want it, how we get it, and it has to be considerate of the limitations that we have with regard to many factors. And it is a bit of a Rubik's Cube, frankly.